Good afternoon, everyone. Thank you so much for joining today's Tuesday topics, managing and monitoring CO2. Now, most of us feel pretty good about our understanding about carbon dioxide, and that is fantastic. Hopefully, you'll learn a few things here about managing CO2. We're going to talk about kind of CO2 in the big framework and talk about production and elimination and regulation. And then we're going to talk about ventilatory management, both with BiPAP and with mechanical ventilation to help your patient eliminate carbon dioxide. So again, thank you for joining today's Tuesday topic. All right, so always important to start off with just a remembrance of what gas exchange is about. So we always think of gas exchange, we're talking about the respiratory system, is about the continuous absorption of oxygen into the blood and the excretion of CO2 out of the blood. Now that is actually external respiration, which is exchange of gas from the atmosphere or from the percent FiO2 into the lungs, into the blood, and out of the blood into the lungs and out into the atmosphere. So I always refer to it as oxygen upload and CO2 download. That occurs at the lungs. But then I want to remind you about internal respiration, which is really where you get the name respiratory acid from. Internal respiration is about the exchange of gases between the blood and the tissues. Now, this is a really critical point in terms of understanding, managing, and monitoring CO2, is that you always have to think about CO2 production during cellular respiration. So, of course, we have cellular metabolism and the metabolic acid hydrogen, and cellular respiration, which also produces hydrogen, which is then transported in a dissolvable gaseous form, CO2. So our purpose when we talk about ventilation is to regulate external respiration by either our tidal volume and respiratory rate, by looking at pressure support and other mechanisms. And when we talk about internal respiration, that's always about blood flow dynamics. So external respiration, typically we're going to evaluate and manage by ventilation. Internal respiration, which is the CO2 production at the cell, we're going to manage by blood flow. And those are two completely separate points when we're talking about gas exchange. So again, if we remember, ventilation is about the process of moving gas in and out of the lungs. Respiration is about the utilization, production, and transport of gas at the tissue level. So we really want to separate that. Although at the bedside, when you say a patient has respiratory acidosis, almost everybody is looking at the ventilator and they're going to regulate the ventilator. But I want you to remember that it may also be about tissue respiration. So very important to remember that oxygen and CO2 move via diffusion.
What's going on, babe?
Hi, my friend. Make sure that you muted
Oh.
yourself. Sorry. Okay, please make sure you mute yourself. We love to hear your conversation, but better if you mute, especially, just in case anything is going on that's personal. Okay, so when we're talking about gas movement, it moves based on a diffusion gradient from a higher concentration to a lower concentration. So on room air, the percent of atmospheric pressure, which is barometric pressure, the percent of barometric pressure that is oxygenated is 21% or 0.21. That means that 0.21 times barometric pressure, 760, equals a partial pressure or a pressure gradient of oxygen at 159 millimeters of mercury. So when I'm breathing room air, I'm breathing 159 millimeters of mercury of oxygen. Okay. In the capillaries in the pulmonary vault, the oxygen content is around 40. So you can see that as long as oxygen gets to the alveoli and as long as there is blood flow past the alveoli, oxygen will move down a pressure gradient. It will be downloaded from the alveoli into the blood via that pressure gradient. CO2 is at around 60 millimeters of mercury in the cells, and in room air, in the atmospheric pressure, CO2, the partial pressure of CO2 is at around 1. So that's really important because this is a really wide gradient. And that means that we're going to move CO2 really rapidly because it's going to move from the blood into the alveoli and out to the atmosphere down a pressure gradient. So two things that happen to our patients is they're producing more CO2, or they're actually having a failure of alveolar recruitment and alveolar ventilation, which will allow them to mobilize their CO2. So anybody who's been on my talks before, I talk a lot about comparing blood gases, talking about arterial blood gas and venous blood gas. The arterial blood gas is fantastic for monitoring lung oxygenation and lung ventilation. When I look at PaCO2, normal 35 to 45 millimeters of mercury, PaCO2 is reflecting the CO2 that remains in the blood after elimination via ventilation has occurred. It doesn't tell me anything about the cells. It tells me about the lungs. It tells me about oxygen into the alveoli and into the blood, CO2 in the blood vessels and the pulmonary vessels into the alveoli and out into the atmosphere. ABGs are really most particularly about evaluating the lung oxygenation and lung ventilation. Now, the base deficit, the pH, are going to be reflections of what's happening at the cellular level, but they are not absolute measures. When I talk about a venous sample, so I want to be very clear here, when I talk about a venous blood gas, my preference is always, and what's reliable, is a venous blood gas or a venous sample drawn from a central line, the brown lumen of your central line, or from your PA distal port on a pulmonary arterial catheter. That is the ultimate VBG. CO2 is 40 to 50. If it's less than 40, it means that your tissues are basically at risk for being hypoxic. We always want to see a PVO2 of greater than 40, but typically less than 50. So you have a range of about 10. The PVCO2, which is remarkable in terms of what it's telling us about our patient, is typically 40 to 50. If the PVCO2 is greater than 50, what it means is your cells are most likely producing high levels of CO2. And what that means is you have poor blood flow. That's it. That's it. It's so important to be able to look at that and provide meaning in relationship to that situation. So really, really important to remember, I want to look at your PVCO2. Now, PVCO2 up and arterial CO2 down, you're producing a lot of carbon dioxide at the cellular level. You have hypoxic tissues that are producing excessive CO2. They are also producing excessive metabolic acid. And the only way to treat that is to improve blood flow. Now, there are some other things that we can look at. We're not going to look at them today, but we can look at them at another time as we talk about the venous minus the arterial CO2, and that difference should always be less than 10. Anything greater than 10 indicates to us that we have very poor blood flow. I have no other way to look at cardiac output, but I do a venous gas and an arterial gas. And if the difference between venous and arterial CO2 is greater than 10, that indicates that I have poor cardiac output. So very, very important when we're looking at our patients and we're understanding that. Okay. And we know that another endpoint for resuscitation is to look at the reserve oxygen. That's the oxygen bound to hemoglobin. That's the saturation of your central venous or your mixed venous sample. So we're really not going to talk much about that today. We're really going to focus on basic CO2 and a major issue that occurs. Respiratory acidosis, which basically means you have an increase in your PaCO2. Okay, so level of PaCO2, that's the carbon dioxide in the blood, after blood has passed through the pulmonary vault and elimination has occurred. What we're gonna remember is that's the first issue, the rate of alveolar ventilation. Now, when we talk about alveolar ventilation, the majority of us are really going to remember that when we look at our ventilator, so we use a Puritan Bennett. Up in the upper right-hand corner will be a V with a dot over it and a small e. and that's going to be somewhere between 6 and 12 liters per minute. That is the minute ventilation of the alveoli. You set a tidal volume to be delivered on your ventilator, but what you see up on the upper level is VE, not with the dot over it, VE, that's your exhaled volume. That is your alveolar ventilation. So really important to appreciate that I might set a tidal volume of 300, but my patient may be exhaling 220. Now, if he's only exhaling 220, he doesn't have great alveolar ventilation, and he's probably going to have some CO2 retention. So very important to remember, first and foremost, something we can really easily control is the rate of alveolar ventilation, which regulates your CO2. But the other thing that's really important is the rate of production of CO2. And that's what happens at the cellular level in cellular respiration. So there's a very nice formula. K is a constant of blood flow times the volume of CO2 divided by alveolar ventilation. We're not going to worry about that. It's important to know there are all kinds of calculations that can be performed. What we're going to do is when we see on arterial gas, your PA CO2 goes up, an increase in PA CO2 occurs because there's too much CO2 in the inspired gas. There's a lot of dead space. That means it's kind of holding on to the CO2. And when the patient inhales, they're getting a CO2 mix. Their alveoli are not well ventilated. You're going to address that with minute ventilation, tidal volume times respiratory rate. And they may be increasing the production of CO2 at the cellular level. And we're going to address that by cardiac output. So here, presence of excess CO2 in the inspired gas, we're going to need our respiratory therapist. We're also going to ask our respiratory therapist to address minute ventilation, tidal volume times respiratory rate to clear more CO2. But the increased production of CO2 by the cell is only going to be evaluated, monitored, and managed because you actually looked at PV CO2. So in your central vein or your mixed vein, looking at the CO2 production. If I've increased CO2 production, I can only answer that by increasing my stroke volume and cardiac output. So I get a lot of information from evaluating CO2 when I'm looking at my patient trying to make good decisions. Okay, so we understand that when the term is used, hypercapnia, typically when we say hypercapnia, we mean that there's excessive CO2 in the arterialized blood, and that hypercapnia usually occurs in association with hypoxia when I am hypoventilated or if I have a circulatory deficiency. So I have a poor blood flow dynamic or I am not appropriately ventilating my alveoli. Now, that's going to be really important as we move forward. And we talk about things like lung protective ventilation, where we've chosen to hypoventilate the alveoli to protect them from stretch and strain and stress. But what that means is that I'm going to accept a certain level of hypoxia and I'm going to accept a certain level of hypercarbia, which means I'm going to accept a pH that is acidotic. Those are things I have to consider when I'm making good decisions about what's going to happen next for my patients. So always really important to remember in acute respiratory acidosis, the CO2 is elevated beyond the upper limit of the reference range. So typically that's above 45 and the pH goes down from perfect. Down from perfect. It could be in range, but it's down from perfect. Okay. In chronic respiratory acidosis, typically you've had time for compensation to occur. And basically we're going to take a sow's ear and make it into a silk purse. So you might have heard that before, a silk purse from a sow's ear. In chronic respiratory acidosis, the CO2 level is elevated, but there's been time for the kidney to conjugate that CO2 into bicarbonate by marrying the carbon dioxide to another oxygen and a hydrogen, which then makes it into bicarb. So what that means is if I have chronic respiratory acidosis with a high PaCO2, I can only have an in-range, not perfect, in-range pH if I have appropriate kidney function. If I have renal dysfunction and chronic respiratory acidosis, my pH will plummet because now I've lost my major compensatory mechanism, which is the kidney uses the carbon dioxide in the conjugation of bicarb or in the genesis of bicarb. Kidney uses CO2 in the genesis of bicarb. You cannot compensate for chronic respiratory acidosis unless you have good kidney function. By the way, don't underestimate the importance of the kidney. The kidney is profoundly important because of this role and many others as well, of course. All right, so what happens when I have CO2 retention and I have respiratory acidosis? I'm going to significantly impact myocardial contractility. It's also going to promote very significant vasodilation, and in particular, in the cerebral circulation. Now, some of you might remember, many of you might be really new, but some of us have been around for 10 years or more. 10 years or more ago, if you had a patient who had increased intracranial pressure, the first thing you would do would be to hyperventilate and blow off CO2. Now, the reason you blew off CO2 is because then the vessel would, the cerebral vessel in particular, would constrict. Okay, so when the cerebral vessel would constrict, that would reduce the ICP, but it also reduced the blood flow transporting oxygen to the cerebral tissue. So the reverse here is true. If I have increasing CO2, I will have significant and profound cerebral vasodilation, which means that I'm going to have more blood flow into the cranial vault and the ICP is going to go up. So something really important to remember is in any patient, we will always have concern with a rapid increase in CO2 because I have a rapid respiratory failure. If I have a rapid increase in CO2, I'm going to have cerebral vasodilation. Whether that patient is head injured or not, that's going to increase their intracranial pressure. So really important to remember that we really don't want to see an increased CO2, in particular in patients who are at risk for increased intracranial pressure, but in all critical patients because of those effects. Now, what typically is going to happen early on, if you have mild to moderate CO2 retention, is you're going to actually enhance your cardiac contractility, trying to improve blood flow dynamics so that CO2 will get reduced. And that's really important. But if it's severe, that's going to significantly impact cardiac function and cardiac contractility. It displaces ionic shift and reduces the cardiac contractile mechanism, which means in the end, your cardiac output is dropped. Well, your cardiac output drops, you're going to make more CO2 at the cellular level, and you're going to be placing more burden on the lung because you're asking the lung to clear that increased CO2. Really, really important. In the kidney, salt and water retention is going to occur with chronic hypercapnia, particularly if we're talking about cardiorenal syndrome or cor pulmonale, meaning pulmonary hypertension. So again, really important to recognize the role of the kidney here. The role of the kidney when I'm in heart failure or I have hypotension or I'm in shock is that I have a reduced volume and pressure to the kidney that stimulates beta stimulation. It also stimulates renin to angiotensin and aldosterone. Angiotensin, remember, is a hormone that causes vasoconstriction. Aldosterone is a hormone that promotes salt and water reabsorption. And so that's going to profoundly affect my patient's venous volume load, my cardiac volume load. Hopefully, it's going to increase arterial volume load, but in most cases, it doesn't. Okay, and of course, what we also see in those patients, kidney failure with chronic hypercapnia or kidney dysfunction with chronic hypercapnia, is that they're going to have an increased circulating level of vasopressin and an increased circulating level of cortisol. Neurologically, we're going to refer to this CO2 retention, this chronic respiratory acidosis, with its neurologic impact, is that you're actually going to have irritable stimulation of the cerebral cells. We call that hypercapnic encephalopathy. So whenever you see patients who have irritability, acutely irritability, not just that they're a mean person that's just irritable all the time, but an acute irritability, change in level of consciousness, headache, apathy, confusion, delirium, and with frank papilledema. Those are really the most important ones that we look at. Motor disturbances like seizures happen a little bit later. You can see myoclonic jerks. You can see a flapping tremor that doesn't really look like a seizure, but it is a form of disruption of depolarization. Very important when we're looking at those neurologic manifestations. So remember that severity of neurologic manifestation is dependent on how rapidly you've accumulated CO2. So again, reminding ourselves that the chronic CO2 retainer has actually accommodated for that CO2, that it's really the acute CO2 hyperproduction or failure to eliminate that we've got to be all over because of the secondary effects that occur for those patients. So again, I want to remind you that the most common reason that we see respiratory acidosis, high PaCO2, is because we have poor alveolar ventilation. Aren't you happy? Because in general, that's something that is relatively, not always, relatively easy to treat by increasing tidal volume and or respiratory rate, and by making sure your patient has time to exhale between each breath, okay? Circulatory is much harder. It's harder for you to evaluate. It's harder for you to discuss. It's harder for you to get somebody to do something about. But it is vitally and profoundly important. If the flow of blood is so poor that CO2 is not cleared in the lung, or we have respiratory acidosis at the cellular level, that is telling you that you have a patient with poor blood flow state. You've got to try to adjust their blood flow state. You'll give volume, you might give inotropes. Vasopressors are not going to improve blood flow state. They usually reduce blood flow state. So we've really got to pay attention to this. If we're fortunate enough to have a central line, as we titrate up on vasopressors, we should be looking at a venous sample to actually evaluate the presence or worsening of metabolic acidosis and the presence or worsening of CO2 production. CO2 production, just remember, you all know what arterial CO2 is supposed to be, 35 to 45. Add 5 to that, 40 to 50 is venous CO2. Whenever venous CO2 is higher than 50, you have to look and see, is the arterial CO2 elevated as well? Or is the arterial CO2 normal to low because the patient is hyperventilating, and they're hyperventilating in order to clear that excessive CO2. So really, really important. So I've just given you this very simple graphic here to remind you about the 3 CO2s that are vital for us to monitor. Produced CO2, produced by the cell and exposed as partial pressure in the venous blood gas. Production, PvCO2, that goes up when cardiac output goes down. Period. Eliminated CO2, that's your end-tidal CO2, okay? Eliminated CO2 is a reflection of your blood flow through your lung and your alveolar ventilation. So I'm always going to want to actually attach, if at all possible. I can do it with a mask. I can do it with BiPAP. I can do it with the nasal cannula, and I can do it with the ET tube. I always want to monitor end-tidal CO2 if I can, because what that is telling me about is the appropriateness of the ventilation. Now I'm going to hyperventilate when I'm presented with higher levels of venous CO2. If I can, I will hyperventilate to clear that CO2. But what's really important for us to remember when we talk about end-tidal CO2 is end-tidal CO2 is a volumetric measure. That means it's not just one and done. It is CO2 clearance over time. In hyperventilation, you have a very short time of exhalation. So each breath is clearing a smaller amount of CO2 because it's a short time, but you're breathing really rapidly. So when I hyperventilate, end-tidal CO2 should go down. When I hyperventilate, end-tidal CO2 should go down. And if my hyperventilation is functional, my arterial CO2 will go down. The best thing I can say to you, just in a really simple format, is when you're monitoring CO2, arterial CO2 and end-tidal CO2 should always travel in the same direction. If end-tidal CO2 is high and arterial CO2 is high, you know one thing for certain, and that is that you're hyperventilated. End-tidal high, arterial CO2 high, you're hyperventilated. When end-tidal CO2 is low and arterial CO2 is low, you are hyperventilated. Both high, hypoventilated, both low, hyperventilated. I'm clearing a lot of CO2 and I'm doing it rapidly. Now, that doesn't seem quite right in the way we think, because we're saying, well, if you're clearing a lot of CO2, end tidal should be high. But we're only looking at the clearance per breath and that volumetric CO2, clearance per breath. And because I'm breathing rapidly, I'm clearing smaller amounts, but I'm clearing over a minute's period of time, much more CO2 because I'm breathing rapidly. Okay. Now, end tidal and arterial CO2, for most people, that offers a comfort level. Generally, they're pretty comfortable with that measurement and that understanding. It's the PVCO2 that doesn't seem to be quite as comprehensive for folks. So I want to just make sure we're just comparing. Okay. So you can see I kind of got a little bit off kilter here in my setup because I don't know what happened when I put it on this framework, but it shortened my screen. But it doesn't matter. Venous CO2 normally 40 to 50, arterial CO2 normally 35 to 45, and end tidal CO2 is actually 30 to 40. So here's what I want you to remember, the simplest thing for us to think about. Simplest thing for us to think about. We all know the normal arterial CO2, 35 to 45. Add 5 on either side, that's your venous CO2. Subtract 5 on either side, that's your end tidal CO2. That's the range, okay? So arterial CO2, 30 to 45, normal range. Venous CO2, add 5 to either side, 40 to 50. That's the normal range. And tidal CO2 is typically 30 to 40, but you can also just apply, it should be around the same as your arterial CO2, and that's okay as well. So we're now going to look at this patient whose venous CO2 is 72. So that's really high. It should be 40 to 50. It's 72. That's really high. Arterial CO2 is also really high. So the problem really isn't production, because I still have a lot of CO2 in my arterial bed. And when I look at end tidal CO2 is 58. End tidal is up, arterial is up. The first thing I can address is that my patient is hypoventilated. I need to increase their ventilation to try to clear more CO2. Yes, I have a high presence of CO2 in the venous bed, but I also have a high presence of CO2 in the arterial bed. So before the cell, before the veins, I already have a high CO2. And then because my end tidal is also up, this is a hypoventilated patient. Okay, now let's look at this patient. Venous CO2 is 58, that's high. Arterial CO2 is 35, that's normal to low. That means I'm making a lot of CO2, but I'm clearing it. And when I look at the end tidal CO2, the end tidal CO2 is low, the arterial CO2 is low, the venous CO2 is high. I'm producing a lot of CO2. What I need to do now is not change anything about ventilation. And if I didn't look at the venous CO2, I wouldn't even know it was elevated. That venous CO2 with a normal to low arterial CO2 and a normal to low end tidal CO2, that venous CO2 is actually telling me that I'm hyperproducing carbon dioxide. I'm hyperproducing carbon dioxide. This is a cardiac output failure. Oh my gosh, can you believe it? Such a simple thing from just monitoring and evaluating our CO2. So CO2 is up in the venous bed, normal to low in the arterial bed, and low in the end tidal. Elimination. This is a production problem. It's a cardiac output problem. Okay, so what am I going to do? Okay, so first of all, I'm not talking about how to increase your blood flow in this talk. But remember, if your venous CO2 is up and arterial and end tidal are down, your patient is hyperventilating, clearing highly produced CO2, you've got to address that with cardiac output. I want to address alveolar ventilation CO2. So the first thing that I can do, first thing that I'm going to consider is putting oxygen, high flow oxygen, CPAP on a patient. None of that is going to help them to regulate CO2. Those are all about oxygenation. I want to regulate CO2. Okay, so really important to remember that when I put a patient on BiPAP, I'm using 2 levels of pressure. The low pressure promotes oxygenation, and the higher pressure promotes a tidal volume. For BiPAP, that's going to be known as IPAP and EPAP. EPAP maintains alveolar opening, and we adjust that to address oxygenation. IPAP is going to actually determine my tidal volume. So the difference between the two determines the tidal volume. And that's what I'm going to do to address a patient who is retaining CO2. Now, I'm going to put you on BiPAP if I need to clear CO2. I'm going to put you on BiPAP with a secondary benefit that I can promote better oxygenation. But I only choose BiPAP if I need to regulate CO2. If I need to promote better oxygenation, I'm going to use nasal cannula, a mask, a venti mask, a non-rebreather, a high flow oxygen, a CPAP, but I don't need anything that mimics tidal volume. Tidal volume is what clears CO2 in alveolar ventilation. So that's going to be really, really important. IPAP always has to be higher than EPAP, and usually there's about a 5 centimeter difference. So I put a patient on BiPAP and they're hypoxic, I'm going to go up on their EPAP. EPAP is the same as PEEP and it's the same as CPAP. EPAP, exhaled positive airway pressure. I go up on their EPAP, but if I go up on EPAP, I have to go up on IPAP because I must always have a difference between the two. If I put a patient on BiPAP and they're still retaining CO2, but their oxygenation is good, all I have to do is increase their IPAP. As I increase the IPAP and I make the difference between IPAP and EPAP wider, that means my patient's going to move more tidal volume. As they move more tidal volume, they're going to clear more CO2. So this is fantastic. It's a fabulous thing. We should always consider and discuss whether or not a patient is a candidate for BiPAP if they are CO2 retaining, that's a new word, if they are CO2 retaining and or if they are CO2 retaining and hypoxic. If they're hypoxic only, I do not put them on BiPAP. BiPAP is designed to help remove CO2 by supporting a tidal volume. And that's the difference between the IPAP and the EPAP. Okay, so when we look at this, you can see here's IPAP, here's EPAP. The difference between the two is what supports tidal volume. And it's very much like pressure support. Pressure support is set in order to help me mobilize a certain tidal volume. Tidal volume is what clears my CO2. Okay, so the expiratory pressure, EPAP, is much like PEEP and CPAP, and that actually helps me to improve oxygenation. So this is a visual of a patient who is on pressure support ventilation. And with that pressure support, what we're doing is as the patient initiates a breath, gas flows into the lung to generate a certain pressure that opens the airway and it allows the patient to move a better tidal volume. That's what our purpose is. That's why we do it. It's fantastic. And it's a really great way for us to manage patients. But what I want to show you here is something that's really important, and that is exhalation time. Exhalation time is the time between the end of your inspiration to the beginning of your next inspiration, and that's your exhalation time. Exhalation time is what allows you to remove your CO2. You remove CO2 during exhalation. So you must take incredible caution at the bedside when you have patients on mechanical ventilation. You have to take a significant look at their cycle time. So when we start off with ventilation, our patients on 12 or 15 breaths, their cycle time is 5 seconds, approximately 5 seconds, a little bit less, a little bit more, but approximately around 5 seconds. Some component of that 5 seconds is spent in inhalation, and the rest is spent in exhalation. We always want to assure that our patient has time for exhalation so that they can regulate their CO2. So again, I'm going to set IPAP, and the maximum I'm going to ever do is 40. I would never do 40. At 20, I think the patient needs to be intubated, but IPAP, you can set up to 40. That's what supports tidal volume, and that's what supports your CO2 removal. This is an inspiratory support effort, and it promotes a better tidal volume. EPAP, that's your expiratory pressure. The max on your BiPAP is going to be 20. I would never get to 20 personally. I normally would say at 10, I'm going to say, I think my patient needs to be intubated. So the highest I like to go, and I don't even really like to go there, is 20 IPAP and 10 of EPAP. That's the highest I like to go. At that point, my patient really has failed BiPAP and he needs to be intubated and managed with a ventilator. Now we're going to take a quick look at this. This is pressure support ventilation. It's called pressure support ventilation, also known as spontaneous, but I know that I'm giving pressure support because I see under here, under PS, that's for pressure support. So I'm seeing that your pressure support is 10. That is 10 greater than your expiratory pressure, which is your PEEP. This is on your ventilator. Your patient is intubated, so this isn't BiPAP. This is pressure support ventilation. An intubated patient breathing spontaneously with every breath, you know that because gas goes in, it's red, gas goes out, it's yellow. If the vent was delivering a breath, it would be green, and you see that big S up over here. Pressure support is 10 of pressure allowed over your PEEP, so 10 plus 8 is 18, and you can see that the max pressure delivered with this patient is 19. So all things are right with the world, things look beautiful. We're doing a really great job, pressure support ventilation. We're supporting our patients' tidal volume, their minute ventilation. Look up here, V with the dot, subset E, that's minute ventilation. That's total ventilation, 11 liters a minute. Exhaled volume, that's alveolar ventilation, 377. Now I go down here and I say, oh, but I'm set at a tidal volume of 440. Well, I'm only exhaling 377. That's on that breath. Maybe on the next breath, you exhale 500. A lot of times people go to the vent and they say, well, why is this exhale volumes different than set volume? That's because this is all dependent on your alveolar recoil. Alveolar recoil occurs during exhalation time, and it's really important to appreciate that you've got to have a standard time for exhalation. Now, if I look at this patient, he's breathing 24 times a minute. So 60 seconds divided by 24 is around 2.1 seconds. That means his in-out cycle is around 2.1 seconds. And really important to recognize that that may not be adequate for my patient to exhale their CO2. So I may need to make some adjustments. I'm not going to do that. I'm going to call the respiratory therapist. When I get the blood gas back, if my patient is retaining CO2, I'm going to call the therapist and I'll say, what do you think? Is it the tidal volume? Is it the respiratory rate? Or is it the time for exhalation? Whenever your patient is retaining CO2 and you are asking about the ventilator, you ask those three questions. Tidal volume, respiratory rate, that equals minute ventilation, and time for exhalation. If you are communicating to a trauma surgeon, they might not really know time of exhalation. If you're communicating to a therapist, they're always going to understand and appreciate time for exhalation. So really important to remember that when we set a patient up initially, after they've been intubated, we put them on assist control ventilation. We're always going to look at what their minute ventilation is. That is their respiratory rate times their tidal volume. And we're also going to consider the time that the gas flows in and the time that the gas flows out. And we're going to talk about that as gas flow or flow rate. Flow rate determines how much of my breath is spent in inspiration and how much of my breath is spent in exhalation. So I'm always going to want to adjust my flow rate when I have a patient who is retaining CO2. I want to try to give them more time for exhalation. But if I push the flow into the lung faster, I must have a lung structure that can accept it. That means that the lung must be compliant in order to accept that volume. That means that your peak pressure should always be less than 35. If your peak pressure, which is the pressure generated when we flow gas into the lung, is higher than that, you're not going to want to flow gas any faster because you're pushing volume and you're pushing flow of gas into a really stiff and tight lung. So tidal volume and respiratory rate. For you, for me, we're spontaneously breathing 5 to 7 mils per kilogram. For ventilated patients, typically we're going to do 6 to 8 mLs per kilogram.
You want in a crate. I gotta go get to them.
Okay, my friends, just make sure you're muted, my friends. Okay, thank you so much. Okay, so 6 to 8 mLs per kilogram. Ideal body weight or predicted body weight, which really has nothing to do with weight, just has to do with gender and height. Our normal spontaneous rate, 12 to 18, and normal spontaneous minute ventilation is about 100 mLs per kilogram of predicted body weight. Okay, so there's a calculation you can do for predicted body weight. Nobody wants you to do it. I just want you to know there's a calculation. But in a calculation table available for you on the internet, that's the ARDSNet PBW table. ARDSNet, ARDSNET, ARDSNet PBW, predicted body weight or ideal body weight table. That will tell you exactly what you're going to set for a patient based on their gender and based on their height. It is important to remember that I could be a 4'8" woman who weighs 200 pounds. My lungs are not bigger. They are the same size, whether I am 4'8" weighing 90 pounds or 4'8" weighing 200 pounds. My lungs are the same size. Lung size depends on the thoracic cage, which depends on your gender and your height. So really important to remember that one of the most important strategies of our current day is that we're going to use a lower tidal volume to protect your lung from overdistension and stress and stretch. That's known as protective lung ventilation. But along with protective lung ventilation comes the possibility and indeed even the probability that my patient is going to retain CO2. So when I use a lower tidal volume, I might use a higher respiratory rate. When I use a higher respiratory rate, I have less time for exhalation. So I have to look at that ventilator, talk with my therapist when I have a patient who is retaining CO2 and they have a high respiratory rate, like that patient, his respiratory rate was 24. He has a high minute ventilation, it's 11, normal minute ventilation is 6 to 8 liters per minute. Okay, that patient was moving 11 liters per minute. That was a high ventilation rate, a high minute ventilation. But what had been impacted because he's breathing so fast was his time for exhalation. He didn't have enough time for exhalation to empty CO2 out of the lung. So what actually happens is he traps dirty gas in the lung. That's known as autopeep. That's dirty gas trapped in the lung because I didn't have time to exhale. That dirty gas is CO2 rich. I have to get rid of that. And the best way for me to do that is to shorten the time in inspiration and prolong the time in exhalation. And my therapist is going to do that in discussion with me when I say my patient's retaining CO2 and they don't have much time for exhalation. Your respiratory therapist will adjust the ventilator, hopefully, if the patient can sustain it, to increase the flow rate, meaning I'm going to push the gas in really fast to allow more time for exhalation. Okay, so always really important that we're never going to be that concerned about an exact tidal volume and a rate. We just want to set this so it doesn't harm our patients. So again, if we look at normal lungs, we move much more tidal volume. We move more tidal volume in our breathing than our critical patients do. In critical patients, they almost always have a restrictive lung disorder like ARDS, like pulmonary edema, like pneumonia, like pneumothoraces. They have a restricted lung disorder. You have to reduce your tidal volume because their lung is much smaller than it would normally be because you've got a restrictive disorder. And as you reduce the tidal volume, you're going to go up on your rate, but you always have to pay attention to the proportional relationship of percent of time spent in inspiration and percent of time spent in exhalation. You always want to spend more time in exhalation unless what you're trying to do is promote better oxygenation. That's a separate issue. We've talked about it before. When we talk about PEEP, we talk about pressure control, we talk about APRV. What I want you to remember today is that in management and monitoring of CO2, when we protect our patients' lungs, we're going to need to increase their respiratory rate. We're going to need to shorten their I time so that we can automatically prolong their E time so they can empty their lungs of CO2. So that just brings me to the last thing I'm going to talk about. I'm going to just mention it again, and that is the rate of gas flow. Ventilators come to you with a default gas flow. That defaulted gas flow is on the low end, and that is 60 liters per minute. So I always remind everybody, I know anybody who's heard me speak before has always heard this, but it really is helpful to appreciate. that I'm going to drive to the airport. The police have closed all traffic, no lights, no speeding restrictions. I'm going to drive to the airport in my VW 1950 bus with flowers all over it. When I put the pedal to the metal, it barely goes 45. Now, Javon has a Lamborghini, a 2023 Lamborghini. When he puts his pedal to the metal, his Lamborghini goes 250 miles an hour. We are both going to get to the endpoint. That's the target. That's the volume target or the pressure target. We're both going to get there. But Javon's going to get there much faster than I am because his rate of speed is faster. So our destination is the same. That's the volume or the pressure that I've set as a control. But the rate of speed that I get there requires that I have a compliant lung, and that allows me to have more time for exhalation. So if you can, if your lungs are compliant, it's best to get air into the lung as quickly as possible. That means you're going to set a higher flow rate. You yourself are not going to do that. The respiratory therapist is going to do it. But your respiratory therapist has 40 or 50 patients, right? So they're barely coming in looking at that vent. They always come when you call, but they're really not strategizing that much at the bedside because they just don't have time. You have 2 patients. Maybe you have 3. Maybe you're in the ECC, you have 4. You have 2 that are on a ventilator. You are looking at that ventilator and you're looking at your patient's blood gas and you are saying, when my patient is retaining CO2, one thing I can do is increase minute ventilation and increase the flow rate if the patient's lung is compliant. I can't do it, but I'm going to call the therapist and say, my patient's retaining CO2. I'm concerned about the cardiac effects, the neurologic effects. Can you help me? Can you adjust the ventilator to regulate the CO2 more effectively? Now, your advanced respiratory therapist is going to make changes and then communicate that to the physician team. They frequently will make changes based on their knowledge and their 4 years of education solely about ventilatory mechanics. They are your best friend when you want to manage and monitor CO2. When you want to manipulate alveolar ventilation, your best friend is your respiratory therapist. They have strategic ways to evaluate and deal with CO2 retention, but you need to bring it to the forefront of their information so that they can come to your bedside and assist you in managing your patient more effectively. I'm going to come to a close today for monitoring and managing CO2. I hope that this has been beneficial for you. I invite you to return tomorrow and next week and anytime in the next year for our Tuesday and Wednesday topics. Every day a different one, every week a different one, hopefully every year, almost every year now. I've been doing it for 2.5 years, hopefully always a different talk every time. I thank you. I appreciate it. For those of you who joined late, I'm going to stop recording, but then I'm going to be available for discussion, questions, and answers. For everyone else watching on YouTube, thank you so very much. I appreciate your attendance, and I hope that this has been meaningful. Monitoring and managing CO2, really important. Thank you very much.